Good morning, everybody. It's 11 o'clock. And in Italy, we are used to be very sharp in time, so we need to start. Please have a seat. And welcome to this symposium, which is entitled Pioneering into the Tomorrow Together. So this is really walking into the future and really to look at what is the potential for new ways to improve the life with people with diabetes. I'm Stefano Del Prato. I'm a diabetologist. I'm a professor of endocrinology at the University of Pisa. And it's my great pleasure to share the floor with a distinguished speaker and very good friends, but even more, to share the discussion with all of you that have found the time to be with us today. These are my disclosures. I've been working with many industry over my career. Now, a couple of housekeeping information. So I'm sure that you already downloaded the app for the program. So if you have not, you can follow the direction here, or you can simply take a picture of the QR code and you'll get there. And the QR code is the key because we are in a symposium. Now, symposium derives from the Old Greek. That means drinking together. We're not going to drink, but we are going to really drink about new information. And since it's a symposium, doing things together, we want you to be part of the symposium. So you can use the QR code to answer some of the questions that will be raised by our speaker throughout their presentation. And we would really much appreciate your feeling, your response through this. Now, you can try now. You can take a picture of a QR code, and there is a question, which is a very important one. And the question is about who designed the Duomo di Firenze. It has been Leonardo da Vinci, Brunelleschi, Raphael, Michelangelo. All right, I mean, you're incredible. You know, you have been visiting Florence, huh? I understand that, and you got all the guide explaining to you how Brunelleschi, designed the Duomo. Although there is one curiosity, you probably have been admiring the cupola of the Duomo. Now, they have not yet figured out the calculation that Brunelleschi did in order to erect that cupola. It still remains a mystery of architecture. So Brunelleschi was the architect designing it and just making that beautiful thing in the center of the town. So Da Vinci, Brunelleschi, Raphael, Michelangelo, all great names, great architect, great artists, but they are not any better than the four musketeers that we have here for our presentation. Can I move to the next one? No, the previous one. The five musketeers that we have here. So as I said before, I'm very fortunate to share this floor with a distinguished and very well-respected expert in the field, Professor Tadej Bartolino, Dr. Federico Bertuzzi, Dr. Yvonne Winhofer, Dr. Emma Wilmot, and Dr. Scott Harper. They will be instrumental to take us through a number of information that will really highlight the potential that we have for improving the life of people with diabetes. And we are here because, of course, we are eager to learn and to hear about them, but also because we do care about people with diabetes. And unfortunately, the number of people with diabetes is growing throughout the world. You know very well the figures. And you know that these figures is going to raise progressively. Now you can see that by 2045, the expected number of people with the diabetes is going to be close to 800 million. And my good friend today is also now suggesting and indicating how also people with pre-diabetes are at greater risk. And if you do add the number of people with pre-diabetes to this, you will overshoot the 1 billion by far of people with problem with their glucose levels. And it's not just the number of people with diabetes, but the growing number of people with diabetes, this is also associated with the growing number of people exposed to the risk of complication. And what is important to really understand or reduce that risk is to know exactly what is happening for their glycemic control. It was Socrates saying, know yourself. I would say, know your glucose, because that can be a very potent guidance for treatment. And actually, connecting treatment with glucose control has been there from the very beginning. You may remember this slide here. This is, that's something that has been circulated a lot a couple of years ago because there was 100-year anniversary of the discovery of insulin, and you can see here, the beagle that has been receiving the first injection of insulin. You see the behavior of glucose, but I'd like to draw your attention here to this page that comes from the diary of Banting and Best, and if you read here, blood glucose sugar 12. Reaction to that? Injected 5 cc's. They are not units of insulin at that time, but it was the first example of how the glucose control, the glucose monitoring dictate the treatment in order to achieve the glycemic control. And this has been obtained in different ways. And what you can see here is a little box, is a paper box. It's something that I was given as a present by a friend of mine. It is a diabetemeter. It was a little box lab that allowed people to measure the glucose into the urine years ago. We are around, the 40s, 1940, or around that time. And since that time, there has been an incredible evolution in terms of how we've been monitoring glucose. It has been an incredible story of a technology advancement. You can see here from the very original one, once again, you can see the diabetometer, the color code assessment, and so on and so forth, and all the evolution, the technological evolution. And the technology is really continuing growing and growing and growing. But it's not just the technology that is evolving. It's what the technology provides us in terms of data and interpreting those data. Let me give you an example. I belong to what I call the UKPDS generation. UKPDS has meant to us a very simple message. Glycemic control can be reflected by the degree of A1C that you can achieve. You may remember 7%, 6.5%, and so on. And that was a revolution for us because having an A1C was a way to try to estimate what was the average exposure to the prevalent glucose levels a person was living in. So it was the average assessment of that glucose level, average. But average is the mean among different numbers, higher and lower. Average can be that you can have the same average value, but with very much difference in terms of the fluctuation of glucose concentration in people with diabetes. Here is an example. Same glucose, same A1C, same average, but very much difference in terms of the coefficient of variation of the fluctuation of that glucose. And both the prevalent glucose concentration and fluctuation may have an impact on the risk of complications. And that's now we have with the technology better way to interpret that. And Professor Battellino, with many other experts, have been championing in giving us new metrics for glucose monitoring, the time in range. And you can appreciate in the natural manner how the more the time in range is high, the better or the lower is the fluctuation of the glucose concentration. So we have different metrics that we can achieve. And those metrics have been initially evaluated and become, thanks to the work of Professor Battellino and the other experts, new metrics for judging the level of glycemic control in people. And these are also evolving. And you have heard here, some discussion about a new potential way to really get better metrics, even stricter, stringent metrics for glucose control. So we have a new potential here. And it's a potential that we wanted to bring to as many as possible people with the diabetes. I started off, mentioning the growing number of people with diabetes. I think that what is important here is also to try to make this, be sure these people can know themselves better. can know how their glucose is behaving, can know what is the outcome of the treatment they have following and they've been receiving. So it's an educated process that we needed to implement to really achieve that glycemic control that can preserve many people with the diabetes by reducing the risk of complications. So this is the overall frame. And now it's time to move into the specific learning items. And we will start off with the presentation of Professor Taddei Battellino and Professor Bertuzzi. They will take us, on the role of the glucose sensing technology in people with type 2 diabetes. Do I need to introduce to you Professor Battellino? Does anyone know him? I think that Professor Battellino has been really instrumental to some of the metrics that we are using today. And I really like to congratulate him for all the work he has done, but also for this fantastic meeting that he has put together with Moshe Phillips. Dr. Federico Bertuzzi is a very well-known diabetologist in Milan, and he has a long-standing expertise in terms of glucose monitoring in people with type 2 diabetes. So without any further ado, I will hand it over to you today, please. And thank you very much again for being here today.
Thank you very much. This was kind. Those are my disclosures for you to review, and disclosures also from Federico. I would like to raise the case, if I summarize it at the beginning, that the use of CGM is useful beyond insulin therapy. So if you let me start with some data. This is a real-world study in individuals with type 2 diabetes on basal-only insulin, so 1 injection a day. And as you can see, those of you that are still interested in glycated hemoglobin, it's a huge reduction. It's not a little bit like we are used in trials, the 0.4 difference for non-inferiority. It is a 1.4% difference when the US cohort is analyzed separately, and a 1.1 when the Canadian part is added into this retrospective analysis. When you look to a similar cohort, again, this is, however, with a different marker. So on your left-hand side, again, those of you that are interested in A1C, but then the rest of the room that are interested in time in range, please note, it's a 12% increase, and we know that anything above 10% is obviously clinically meaningful. So again, in the same population, real-world setting, here the difference. And if you go to non-insulin users, please note that the difference as compared to the basal insulin users is even much larger. We have 300 individuals in the basal insulin use and 700 in the non-insulin use. They were similarly initially, so the A1C had a tragic 10%. But then please note the decrease in non-insulin users, minus 1.6%. So a really impressive change. This is people with type 2 diabetes on basal insulin again, a different study here. This is 1 year before the start and then follow-up of 1 or 2 years after. Please note here the events. So it is a 75% reduction in DKA. This is not only important for well-being of these people. It is obviously important for the cost. And at the same time, an almost 50% reduction in severe hypoglycemia, which again is related to cost. Because of these outcomes that were particularly well studied in France, there is an immediate cost-saving effect of this technology. So you don't have to calculate over 10 years to see the effects of the long-term complications. It is now because of this reduction in acute events that require either emergency department intervention or hospitalization. Here, again, an interesting comparison because you know how much we emphasize education, and education obviously is the base, very important. But if you add to this education the visualization of glucose levels, if you add CGM, intermittently scanned CGM, please note the difference. So time in range, again, a 10% difference, whether you use education alone or you provide these people with the real view of glycemia. So this real view of glycemia increases the outcome, the time in range, for an additional 10%, which I think is an important message. And this is people with diabetes on GLP-1 receptor agonist only. This is now becoming, I hope, a standard of care. So many people, particularly I hope, in early type 2 diabetes, will be on GLP-1 receptor agonists. Is CGM indicated? Please note, yes, because we switch from the focus on hypoglycemia that was so much emphasized with insulin and perhaps sulfonylureas on hyperglycemia. We want to identify early that perhaps the dose is too low or perhaps we have to add something to these individuals. Please note here, so this is again the difference in glycated hemoglobin, 1,800 individuals, including in the study, only GLP-1 receptor agonist, and the drop in A1C with the use of intermittently scanned CGM in this study, 1.5%. So a very, very huge impact in the population that uses only GLP-1 receptor agonists. Here, the combination therapy, as you can see here, again, even a more pronounced result. Of course, you can say this is cherry-picked, right? The studies are designed to give this result. And, perhaps you're correct. I may agree with you, but still, here, if you can see, so GLP-1 receptor, only 2,000, almost 2,400 individuals dropped their A1C from 10 to 8, a 2% increase. Even if it's cherry-picked, the benefit for these people, as you well know from the UK PDS, is enormous. That's why there was a group of us that decided to put an initial view on the roadmap how to use CGM in type 2 diabetes. We believe that all people with type 2 diabetes should have access to CGM, and we specifically mention also people that are non on insulin on sulfonylurea. So the very, very large population, an increasing population that perhaps uses just oral therapy or, as we said, GLP-1 receptor agonists, they may benefit enormously because of the hyperglycemia, of the identification of high glucose that finally causes all the long-term complications in diabetes. Just a very short case for the conclusion. This is a lady, by the way, happy International Women's Day to all our colleagues present. Not very obese, a BMI of 29, diabetes now for 13 years. She is using a sulfonylurea, a DAPA, and an oral sema. Please note that the control, the management is obviously inadequate. Time in range, this is local, our local language, 67% beyond the target, obviously no hypoglycemia, and very, very high values. And as you can see here, you see an early morning increase, so the fasting's high. So perhaps many would start to think about basal insulin. This is what was proposed to this lady. She accepted it, she was trained, and she was started on a second generation basal insulin, maintained DAPA, maintained oral sema. Look at the outcome. Very high, dropped to a single percent. High dropped to 8, so altogether 9% above the target. Within the target, 91%. And please note that the fasting normalized. So, and very interestingly, the BMI went down. So just an example of a combined effect of basal insulin and very likely behavioral change with the use of CGM, because otherwise we would not expect a drop in her weight. With this, I thank you for your attention and would like to invite Federico to tell us more on this topic.
dear colleagues. Thanks for this kind invitation. It's really an honor for me to share the stage with Professor Tadej Bartolino. So thanks, Tadej, for this introduction. The first slide, I would present our experience in type 2 diabetes patient in Italy under basal insulin treatment. Type 2 diabetes mellitus population in Italy is primarily composed of old patients with an average age of 70 years old, with some comorbidities such as chronic kidney disease, 30%, and 14% of cardiovascular disease. This can be represented as fragile population. And according to the Annals, one of the most comprehensive database in Italy on diabetes mellitus, over 20% of type 2 patients are under basal insulin plus oral drugs. And in this cohort of patients, the glucose control is not optimized. Looking at the HbA1c level in this population, they have a worse glycemic control, similar to patients under MDI treatment. So what are the challenges associated with this kind of therapy? Fasting glycemic control can be achieved by a proper basal insulin titration, avoiding hypoglycemia. And postprandial glycemic control can be achieved by selecting the proper oral drugs or by educating the patient to auto-management of the diet. And for both these targets, the availability of the full history of glycemic profiling of this patient is crucial, is very important to optimize their glucose control. So let's discuss my first clinical case. This is a male, 50 years old, low weight, suffering from hypertension, and he has not tolerated CGLT2 inhibitor and GLP-1 analogs. His therapy is glargine 20 units per day, plus sitagliptin and metformin twice per day. He has poor diet compliance and severe hyperglycemia, with a value of HbA1c of 87 millimolar. So the question is, what therapeutical option would you prefer for this patient? Of course, it's very important to stress diet compliance, but please select one of these options, add rapid insulin, stop sitagliptin, metformin, add glitazone, increase basal insulin, or add sulfonylurea. Few seconds to select one of these options. Okay. Very well. Increase basal insulin and add rapid insulin, stop sitagliptin, metformin. Okay, we can stop. We can stop. We can stop the. Okay. And if the glycemic profile are available, would you reconsider your decision? Look at the glycemic profile. You can observe a severe fasting hyperglycemia. Sorry, just a moment. Okay. In this patient, we decided to simply increase the basal insulin level up to 40 units. And we stress, of course, the diet modification. The patient was resistant to start an MDI treatment, and they show a really poor compliance to the diet and to physical activity. So we decided to simply increase the basal level, and if you observe the glycemic profile 3 months later after this modification of the insulin basal therapy, you can observe a significant improvement of his glycemic profile, although it is not optimized yet. Thus suggesting that the observation of the glycemic profile thanks to FGM system aided the physician to define the best therapeutic option for this patient. Move on to the second clinical case. This is a male, 64 years old, obese people with type 2 diabetes mellitus and hypertension, suffering for moderate chronic kidney disease. His therapy consists on CGLT2 inhibitor and GLP-1 analogs plus glargine 60 unit. His glucose control is not optimized with a 60 millimolar of HbA1c level. And the same question, what therapeutic option would you consider for this patient? Select one of these options: diet modification, increase basal insulin, add glitazone, or add acarphage. We can wait. Or most of you, increase basal insulin. Okay. If the glycemic profile are available, would you reconsider your decision? You can observe a significant glycemic variability and some postprandial glycemic peaks. So in this case, the successful strategies was simply the modification of the diet. The observation del glycemic profile confirms some postprandial glycemic peak, but the patient autonomously decided to modify the diet by selecting the proper type of food, reducing the amount of food in order to prevent the hyperglycemia peak postprandial. And diet modification of the patient has led to reduce time above range and increase time in range in this patient, thus suggesting that the possibility to have the glycemic profile aided the patient to the auto-management of the diet, empower the patient to the management of his diabetes. So the conclusion to these cases is that in people with type 2 diabetes, Freestyle Libre system facilitates basal insulin titration and the self-management of postprandial hyperglycemia in people not on MDI therapy. And this paper has summarized our experience in Italy on this type of patient, that are under basal insulin therapy plus oral anti-diabetic drugs. The study was conducted in 2 hospitals, our hospital, Ospedale Niguarda and Ospedale Civili di Brescia, and was an observational retrospective real-world study on 132 patients. The median duration of diabetes was 19 years. The baseline HbA1c level was about 8%. Primary endpoint was the changes in HbA1c level at 3 and 6 months after the use of Freestyle Libre. These are the results. You can observe that the use of Freestyle Libre 2 system in people on basal insulin significantly improve the HbA1c level with a reduction of about 0.4% at 3 and 6 month follow-up. Even analyzing the data in a separate way of patient only in oral drugs or in basal insulin plus oral hypoglycemicant, there was a significant reduction at 3 and 6 months in patient basal insulin plus oral hypo, and at 3 months in patient with only oral hypo. By the analysis of CGM metrics, we can observe a significant decrease even of time below range from the data available at 6 months compared to the data available at 3 months. Baseline data were not available because the patient baseline in this study did not wear the CGM system. So thanks to this experience in Lombardia, one of the Italian region with the largest diabetic population, about 500,000 people with diabetes are in this region. The reimbursement of FGM was recognized by the national healthcare system. And for patients with type 2 diabetes mellitus under multiple daily insulin injection, but even for patients on basal insulin therapy only. In this case, however, the prescription should be limited to 1 year. And after the first year, the physician has to verify the correct use of the device. But this system can be prescribed also for people on hypoglycemic therapy only for 3 months period in the case of some specific conditions such as the risk of hypoglycemic episode, therapy modification, glycemic decompensation. Thank you to you.
Thank you very much, Federico. Let me just remind you that using the same QR code that you have on your system, you can also send me questions or comments that I will then ask the speaker and the faculty. So if there is any comment or question, please feed them in because there is no mic and we'll have the discussion at the end. So thank you very much today. Thank you very much, Federico. This has been very interesting, and I will try to maybe summarize what has been the message. I think that what has been shown here, if I can have the next slide, is that anyhow that the freestyle Libre system can indeed empower people with type 2 diabetes on titration of that basal insulin to achieve a better glycemic control and helping the healthcare provider to support them. And I think that what Federico has shown is that gathering the information or the solidity of the information offer the ground for the payer to consider reimbursement and offer reimbursement of people with type 2 diabetes. And I think this is very important. It is the data that are driven the decision, and they are driven the decision of the physician, but also of the administrators. And I think that today really made a very strong point in suggesting, indicating how the glucose monitoring system and the Freestyle Libre can really offer an opportunity to improve glycemic control beyond the concept of the risk of hypoglycemia, but rather improving how to smooth the glucose profile in people on basal insulin, on GLP-1 receptor agonist, and even on people not on injectable treatments. So at this point, I think that we can move on to the next presentations that are going to be delivered by Professor Yvonne Winhofer and Professor Emma Wilmot. Professor Winhofer is a specialist in internal medicine and in endocrinology and metabolism at the General Hospital in Vienna. And she has been receiving a number of honors and prizes, the latest one being the Diabetes Forum Prize, and is also a member of the board of the Austrian Diabetes Association. Professor Emma Wilmot is associate professor at the University of Nottingham, and she's, just to prove her expertise in the field, the founder of the Diabetes Technology Network UK. And she had a very important experience in terms of education for people with type 2 diabetes. And what Yvonne and Emma are going to develop and illustrate to us is enhancing integration of glucose sensing technology with insulin pens and the AID system. I just came out of an artificial intelligence symposium, and this is another demonstration of how the technology is going to provide us even better opportunity in the near future. So Yvonne, thank you very much.
Thanks, Stefano, for this kind introduction. And it's a pleasure for me now to talk with you about connected solutions of the Freestyle Libre 2 system and the Novo Pen. Maybe you have recognized that now it's not It's not more usable or common that you have to scan the sensor every 8 hours in order not to lose any CGM data. It gets directly streamed with the Libre 2 system as it does with the Libre 3, but also the Libre 2 can do that. And it's updated every minute. And via the Libre Link app, it can be shared with the people's relatives, but with the Libre View, also with the healthcare professionals. But still, people living with diabetes have the opportunity to scan the sensor in case Bluetooth is interrupted. A further novel innovation is the integration of pen data to the Libre app of the smart insulin pen NovoPen 6 and Echo Plus. Just with scanning the pen, the data of the insulin injections get merged to the CGM data, and people can review the impact of the injections on their glucose levels. And it's very easy to do that. You just have to connect the pens. You can save more than one pen and add the information which insulin is inside. And then the system knows the pen, and every time you scan it, you can review it. You don't have to scan the pen every time you inject it. The pens can save up to 800 insulin dosages. But it's recommended to do it at least once a week because then the scanning time is quite short. People can review it in the Libre app, but they can share it also with the healthcare professional in order to improve their insulin management. And that's what I do with the people with diabetes I take care of. And I thought it's easy for you to get into this technology by sharing my experience with this technology with you. This is a 79-year-old woman living with type 2 diabetes since more than 15 years. She had a very early initiation of insulin therapy. Type 1 diabetes was ruled out. She has a BMI of 18 because she's very strict with eating and uses multiple daily injections with insulin degludec and insulin aspart. And on the right side, you can see on a normal day, she injects 14 units of insulin degludec and around 10 units of fast-acting insulin aspart. With that, she has a time in range of 74% and a time below range of 1% and no evidence of glycemic variability. Maybe some of you will ask why such an elderly woman has such a tight glycemic control and such a fancy insulin therapy. But actually, I think that age shouldn't be a limit for good therapy. And actually, this 79-year-old woman is still running a huge company as a CEO, and she wants to do her insulin management as best as she can alone. And she just needs me at the background when she cannot do it alone anymore. So on the 9th of June, she called me saying, Doctor, my glucose is high. Might it be related to the current antibiotics I'm taking as a prevention after tooth extraction? And if people calling me because they have a problem, what did I do? I go to the Libre View and check the days before the call. And that's what I want you to do now as well. Grab your phones, scan the code, and help me answering the question. Do you think what might be the reason for the hyperglycemic excursion in this lady with normally good glycemic control? Do you think she has a current infection after the tooth extraction? She has pain-related hyperglycemia. She missed bolus injections or she missed basal injections. Please vote now. Okay, thanks. Can we get it? Yeah, thank you. Maybe this was a little bit difficult. You really have to go to every day and then you see that you missed 2 basal injections. And if I was telling her that, She didn't believe me, but she knows that I see everything because she knows that her pens are connected with me. And you see, on the other days, she injects both insulin at the same time. And maybe people also tell you this. Sometimes they cannot remember whether they injected the insulin some minutes before. So what we did in this situation, I was just recommending her, maybe the next time, please check both of your pens if you have injected your insulin. So you see, it's very easy. She just forget the bonus, but it's a basal. But I think it's important because what would we have done before? Before I would have had this information, I would just have increased the insulin without thinking what I'm doing. So I think we get into a novel situations because we see that with the data we have from the smart insulin pens. And I want to show you here a study in people living with type 1 diabetes, which showed that the estimated probability of missing at least one basal insulin dose in a given 14-day period is 22%. So it's quite high. And that's keep in mind when you see hypoglycemic excursion, that maybe the insulin was not injected. Let me show you another woman living with type 1 diabetes since her 12th birthday. She has a BMI of 32 kilogram per square meter, and despite the long diabetes duration and the fact that she is obese, she has a really low insulin demand with using insulin degludec, just 11 units per day, and 1 unit per 30 gram carbohydrates of insulin aspart. With that, she has quite good glycemic control with an HbA1c around 7%. Here on the right side, you see the glucose daily logs before her routine visit. And at this routine visit, she's complained about recurrent hypoglycemic episodes and wants to decrease the basal insulin dose. So please, could you please help me again? Grab your phones, scan the QR code, and suggest, what do you think? Do you think that these hypos you see here are related to a too high basal insulin dose? Yes? No? You have no idea? Or you say with an HbA1c of 7, never change a winning team? Excellent. I think we can stop the voting. You all did right. Yeah. That's a frequent finding with these since we have the smart pen data. The hypos are following correction doses. And since we observed that so often, we wanted to look at this data and we made a study investigating more than 18,000 people with type 1 and type 2 diabetes who were on CGM and were starting smart pens. And what we found was that the estimated rate of correction doses followed by hypoglycemia were around 9%, especially in the younger patients aged 18 to 29 years. It decreases with increasing age, but the good news is it also decreases with the implementation of smart pens. If you're more interested in this data, they are presented at this meeting as an e-poster reviewing number 464. Here's my last case, and I already presented this case 2 years ago at the ESD meeting, and so many of you came to me and say, wow, that's an interesting case, how it will develop, because the woman was still pregnant at this time, and therefore I thought I will bring it today, because for me it was really a clinical challenge. This is a 35-year-old woman with MODY 2 diabetes. She has a history of multiple miscarriages, but also a positive pregnancy, giving birth to a girl in 2021 where she had gestational diabetes. And the girl was born small for gestational age. And actually, the girl had a growth retardation within the first 2 years of life. The woman has a genetically confirmed MODY 2 with a low C-peptide and an HbA1c of 6.5% before pregnancy. Since she wanted to get pregnant again, she asked me to start insulin therapy in order to prevent hypoglycemia caused malformations. This is the AGP before pregnancy, and it's very typical for MODY diabetes that they have increased fasting plasma glucose. We started insulin therapy with a smart pen because I really wanted to learn her the best insulin injection behavior what I know. We set the range into the pregnancy range, and I explained her the difference whether she makes the injection, the bolus injections before the meal or after, because afterwards it can also lead to hypoglycemia. After that, she had a really good glycemic control, and as you can see here, in the 23rd gestational week, she used 16 units of basal insulin and 16 to 20 units of rapid-acting insulin. But suddenly, at the 26th gestational week, the fetus had a growth retardation despite normal blood supply. So we had to stop insulin therapy. And that's what you have to do because it's assumed that the baby also has MODY2 and needs higher glucose values in order to secrete insulin. Maybe you will ask, why didn't you do a genetic testing at the fetus? For that, we would have made a punctation. And the woman after multiple miscarriages doesn't want a punctation. So we just stopped it according to the ultrasound data. And despite stopping 30 units of insulin, she had a quite good glycemic control with 83% time in range and gave birth to a normal weight, normal glycemic boy in the 39th gestational week. I want to show you here that clinical cases can be really challenging, and we should take all the support we can get by CGM and also smart pens. And there will come more data also in this study, for one of the first studies showing data with smart insulin pens, showing a significant increase in time in range, decrease in time below range. And I'm sure we will be able to present you more data on smart pens within the next years. So to summarize, we have now the opportunity to connect the data of the continuous glucose monitoring with the insulin injection data, also in those who are using pen. We can work together much more better with our patients, with the people we take care of, as the devices work together, and which further devices work together will be presented by Emma now. Thank you for paying attention.
Thank you. So I'm going to move on to talk about automated insulin delivery. We're going to start thinking about the evidence for technologies beyond real-time CGM, think about who might benefit from access to AID, explore the importance of choice, and look to the future. But I want you to start by going on a journey in your car with your sat-nav, but you're only allowed to look at it 4 times. Not ideal, but this is what finger pricking is for people with diabetes. We want to have all the information, but we don't. You want unlimited views of your sat-nav, and this is what real-time CGM does for people living with diabetes. Guess what? Cars are moving on. We're moving slowly towards automation of your car to the point that you may not have to interact as much. But guess what? In diabetes, the same is happening. We are moving towards automation of insulin delivery and accessing this for people living with diabetes, and it is absolutely life-changing technology. Here we have a recent systematic review and meta-analysis from 22 randomized controlled trials, showing that with automated insulin delivery, we get significant improvements in HbA1c, time in range, hypoglycemia, without an increase in the risks, and most importantly, from my perspective, it reduces the burden of living with diabetes with reduced diabetes-related distress. If ever there's a context where glucose control matters, as we've just heard, it's pregnancy. And at International Women's Day, I'd like to take my hat off to Helen Murphy and Eleanor Scott for leading on the ADAPT randomized control trial, which has very nicely demonstrated the benefits of automated insulin delivery for women with type 1 diabetes in pregnancy, with an adjusted but mean difference in time in range of 10.5%, which will deliver meaningful differences for the mother and baby. But to put this in clinical context with a case, here we have somebody presenting in pregnancy with an unplanned pregnancy, which unfortunately happens far more often than it should do. An HbA1c of 12% on multiple daily injections, but in the context of having not attended clinic leading up to this. They hadn't been monitoring their glucose levels, so in early pregnancy we start on glucose monitoring. You'll know that we are aiming for more than 70% time in range in those tight glucose targets in pregnancy between 3.5 and 7.8, and here we're achieving 22%. We're having to start education with carbohydrate counselling, insulin to carbohydrate ratios, correction factors, encouraging her to bolus before she eats, and we offered her the opportunity to move to automated insulin delivery with the CAM APS FX system. I'm delighted that she took us up on that offer, and within 2 weeks of using the system, her time in the pregnancy target ranges shot up from 22% to 49%. I tell you from my clinical experience, this is extremely difficult to achieve in such a patient on multiple daily injections. We required ongoing optimization, and for those of you that are used to using these systems, a key thing is making sure that that bolus insulin is given before the meal rather than at or after the meal. As with all women with type 1 diabetes in pregnancy, as the pregnancy progressed, we tightened insulin to carbohydrate ratios. We continue to support weekly, looking at diet, looking at insulin therapy and optimization. By 28 weeks, she had dropped her HbA1c from 108 to 50 millimoles per mole. Her time in range has increased from 22% to 65% in what started off as an extremely high-risk pregnancy. But most importantly, she delivered at 37 weeks a healthy baby born by caesarean section. This is what technology is capable of supporting women to achieve. And actually, when I reflect back on the randomized control trial data, there's often a disconnect, particularly with AID, in terms of what I see in my clinic and what the trials are reporting. And that's because real world is very different to the people that are typically recruited to randomized controlled trials. So we looked at the real world outcomes in the UK of people transitioning across to automated insulin delivery. Being included in this analysis, they were on pump therapy, the Freestyle Libre, and had an elevated HbA1c, and we report the data on 520 individuals with follow-up. We looked at 6 months of follow-up data and a range of different outcomes, but I'll walk you through the key take-home messages. So we saw a dramatic improvement in HbA1c, 1.7% reduction, reducing from 9.4 to 7.8%. Time in range improved from 34% to 62%. Now, this may not be as high as what you see in the randomized controlled trials or the wilder real-world data, but the reality is when you take people with very high HbA1cs across to this technology, any improvement is beneficial, and that is a substantial improvement for these individuals. But perhaps most importantly, again, looking at diabetes-related distress, at baseline, 69% felt overwhelmed by living with diabetes and felt like they were failing. At follow-up, only 23% felt that way. But fundamentally, the evidence base that's been developed over recent years, the real-world data, have fed into an analysis by NICE in the UK, who have evaluated hybrid closed-loop therapy and have decided that we should have legally mandated access to automated insulin delivery systems for a range of people living with type 1 diabetes. Those with an HbA1c above 58 millimoles per mole, those with disabling hypoglycemia, and from NICE perspective, that is when hypoglycemia occurs frequently or without warning, so that the person is constantly anxious about having hypoglycemic episodes, despite the best possible management. It's recommended in those who are pregnant or those who are planning pregnancy, and in all children and young people. This is a watershed moment in the care of people living with type 1 diabetes, And I am absolutely delighted to be a diabetologist where my job going forward is just to continue to change lives for the better. And actually, we're also in the era where we now have a variety of commercial systems available, enabling choice for the person living with diabetes to work out what system meets their individual needs. And let's be honest, as healthcare professionals, it can be quite daunting walking people through that journey. There are a number of factors to consider, but it's actually really important that we take our time out to ensure that we do this properly, because these bits of kit are potentially going to be attached to the person for 4 years. So when we look at the sensor component, you want to consider the accuracy of the sensor, the size, how long is it worn for, where on the body can it be worn, how easy is it for that person with diabetes to use it. When we look at the actual hybrid closed loop system and algorithm, what's the evidence base underlying that system? What's the license? What populations is it available for? What's available with your local funding arrangements and in your country? And is there phone compatibility issues to consider? Then when we think about the pump, we're thinking about the size, the interface, how we update the software, the set changes, the cannula types, the reservoir size. It takes a while to go through these things, but we have to ensure that people with diabetes are equipped with information about this so they can make informed decisions. Now, it's beyond the scope of this talk, but in the UK, we've developed a best practice guide, which has very practical recommendations about supporting people transitioning across to hybrid closed loop therapy, which is open access. So please do Google DTN best practice guide, and you'll be able to access this to look at. So I want to quickly do a survey. We've got many countries in the room. Let's explore what access you've got. So this is Laura, who's 48 years old. She's got type 1 diabetes and multiple daily injections, and her HbA1c is elevated at 67 or 8.3, despite education and access to real-time CGM. In your country, could you access automated insulin delivery for this person living with diabetes? If you can submit your responses now as a yes or no, and we'll see what comes through in the word cloud. So it looks like the majority of the room are a yes. Definitely, I like it. Wow, that's inspiring. So the majority of people, by the looks of it, will be able to access automated insulin delivery for this person. Okay, I'm moving on to the next case. So again, we've highlighted the importance of glycemic control in pregnancy and access to the best support. So here's Katie, who's 26 years old, type 1 diabetes, unplanned pregnancy with an HbA1c of 67 or 8.3%, despite multiple daily injections and access to real-time CGM. In your country, could Katie access closed loop therapy for the duration of her pregnancy? So submit either yes or no. So again, the majority seem to be coming through yes. Some have got sort of saying private insurance. But again, this is amazing. I'm really excited to know it's not just the UK where we're finally managing to get the technology into the hands of people living with diabetes. So let's look to the future and what the future holds. Well, in terms of the Abbott offering and the systems that are coming through, and again, not all of these systems will be available in all of your countries, but we have the opportunity now to link the Freestyle Libre 3 with a Ypsomed pump with CAM APS. And we also have the Freestyle Libre 2 Plus linking in with Omnipod 5. Now, I'm in the fortunate position to be the chief investigator on the Radiant randomised controlled trial, where we are currently recruiting 200 patients from the UK, France and Belgium into this trial, which recruits people with a high HbA1c, on multiple daily injections and on the Freestyle Libre. and then randomizes them either to the Omnipod 5 with the Freestyle Libre 2 or the control arm. And I'm very much looking forward to reporting those results in the future, as this is the first randomized control trial looking at those transitioning from multiple daily injections to the Omnipod 5 in both adult and pediatric participants. Now, obviously, I can't share the results of the study yet. It's still underway, but I will provide you with some of the feedback from 2 of the participants in my study. So this says, I have been getting on really well so far. I love the freedom that the system gives me without the need for injections. It's very simple and user-friendly. I do feel like it has a huge positive impact on my diabetes, and it's undoubtedly changed my life for the better. A total life changer. I feel all the restraints of being diabetic have been lifted. I can now do what I want, when I want, and eat whenever life suits. I don't suffer highs and lows like I once did, and my temperament is much better. I feel far more relaxed with stable, lower blood sugars. My family have noticed the difference in me. They no longer worry about how my diabetes is doing. In conclusion, would recommend anyone to use this. It makes you feel human again. Really powerful words. So, Chair, ladies and gentlemen, in summary, the use of diabetes technologies is expanding rapidly. The changes we've seen in the last decade are mind-blowing. And the next decade is going to be just as exciting as we see the expansion of automated insulin delivery to improve glycemic outcomes, but most importantly, improve the lives of people living with diabetes. The choice of system is important to the person with diabetes. It requires thought and detail. And again, we need to equip ourselves with all the knowledge to be able to impart that to the person with diabetes during their consultation. And we also have a growing number of systems which are offering compatibility with the Freestyle Libre sensors. Thank you very much.
Thank you very much. Thank you very much, both of you. I received in the meantime some questions that we'll be dealing with in the discussion, but I invite you again to, to send in any curiosity, question, comments you may have. So I think that what we heard has been once again, very informative. My take away messages that I'd like to propose to you are the one that you can see here on the screen. So the automated insulin delivery system has shown clear evidence to improve A1C and TIR in patients with type 1 diabetes, but there are multiple AID options that may provide people with diabetes and clinician flexibility to match their needs, and we heard about a number of cases. And the Freestyle Libre 2 Plus and Freestyle Libre 3 sensors are designed for one easy-to-use integrated experience. And I think that our 2 speakers did a fantastic job, but I would really like to congratulate them in a specific manner today, being given the fact that it's the International Women's Day. I really like to extend all the wishes to all the ladies and the women and the colleagues and the physicians that are with us today. Now, let's move to the final presentation, which is going to be delivered by Dr. Scott Harper. Dr. Harper is the Divisional Vice President of the Research Development for Abbott's Diabetes Care Business, but that is the title, that is the position. What Dr. Harper really is the driving force behind the development and the innovation of the Freestyle Libre system. And since it is in charge of the innovation, I think that is going to take us into the future of the innovation for the Freestyle Libre. Please, Dr. Harper.
All right, well, thank you for that introduction. I'm really excited to have this opportunity to speak with you all today and to just, follow these excellent speakers. Today, I'll talk a little bit about the progression that we've seen in analyte monitoring over the years and talk a little bit about what we see coming next. So my disclosure, I'm employed by Abbott. I've worked with Abbott 20 years now. and been working in CGM for almost 25 years. And I've been coming to these conferences with many of you for the last couple of decades, and it's really impressive how far we've seen CGM come in the time frame in that last couple of decades. And I'd say in particular in the last 10 years since Freestyle Libre was introduced. I think it's really changed the way that diabetes is managed and glucose testing is done. So in the last two sessions, we saw uh, some really good overviews and insights on how CGM can be used in people on basal insulin and also on people that are on non-insulin therapies. And we've seen the great benefits the technology can provide in terms of improving outcomes of people using the technology. We also got a great insight into how when we connect this CGM data with other platforms, such as smart insulin pens or insulin delivery systems and insulin pumps, that we can get really extra insights into what's happening with the people that are using the product. And so that we can help provide better direction and give them better insights into how to manage their condition. And with the automated insulin delivery, we're just seeing amazing improvements in outcomes and also the quality of life for the people dealing with that, using those systems. So really exciting innovations. And I'd say that despite the growth that we've seen, we're really only scratching the surface. Today, Freestyle Libre is used by over 5.5 million people daily, and countless more are touched or indirectly impacted by diabetes. And so there's been a great benefit there. But as we saw the prevalence numbers at the beginning of this session, there's a lot more work to do here and a lot more people that can benefit. And so I'll now shift gears into a discussion of where we've been, but also what do we see coming next and why are we focusing on some of these innovations? And so sometimes to look forward, it helps to look back. And so, looking back to blood glucose testing, Abbott via Medisense was the first to introduce a biochemical test strip measuring blood glucose with the Exactech meter back in 1987. That really introduced the era of blood glucose monitoring, which went on for quite some time. We saw CGM introduced, for Abbott, our first introduction was Freestyle Navigator in 2007. And so this was a really nice technology for its time. It had strong accuracy performance, fewer calibrations than other systems available at the time. However, in the early years of CGM, it was really more of a niche product used by really only a subset of people with type 1 diabetes. Now, CGM systems at the time had some important limitations that limited their broader adoption. They were, had cumbersome application processes, weren't as easy to use. The parts were larger and maybe uncomfortable to wear on the body. And the systems at the time required adjunctive use and daily calibrations in order to get the glucose data from the system. And maybe one of the most important challenges was that the systems were much more expensive than the blood glucose monitoring at the time, and that really inhibited broader access. Now, in 2014, a decade ago, we introduced Freestyle Libre. This system was designed from the ground up with ease of use, access, and affordability in mind. And I think that this was the first system to really unlock the potential here and really produce a product that was going to be available to a much larger audience. The system was the first system to eliminate user calibration in order to produce results and provide non-adjunctive use, and provide a great simplified user experience with an easy application process, and a small onboard body form factor that was much more comfortable to wear than prior systems. And importantly, the product was designed with scale in mind so that we could deliver it at very high volumes and a very low price to support broad access. And so with this product, CGM really started to be available to the masses, and the strong clinical performance and ease of use opened the door for broad access for people with both type 1 and type 2 diabetes. And in our earlier talks, we saw the benefits that we're achieving in those populations when using this technology. Now we followed Freestyle Libre with Freestyle Libre 2, where we added glucose alarm functionality in the same small form factor as Freestyle Libre, and importantly, at the same low price. And then next, we introduced the Freestyle Libre 3 system, really carrying innovation forward with an incredibly small, thin form factor, excellent performance, and a very simple ease of use with a one-piece applicator design. And I think today we're really in the era of using CGM along with connected systems, either connected with smart pens or with insulin pumps and feeding into smart algorithms that can automate the insulin delivery and really take some of the burden off the people using the product and achieve some fantastic outcomes. Now with ketone monitoring, Abbott was an early innovator, the first to introduce an electrochemical ketone monitoring strip with the QID system under Medisense in 1997. And that really is similar to how ketone is monitored today, either with urine test strips or blood glucose test strips. And we really haven't seen the same level of innovation in the space. Now, despite that relatively quiet innovation landscape for ketone monitoring, it can be an important tool to identify elevated ketones and DKA. Now, I'm showing data here from the RELIEF study, which was a retrospective real-world study of nearly 75,000 people using insulin in France. The population I'm showing here is the population of type 1 diabetes, and there's a couple of points that jump out. This is looking at the hospitalization events for that population in the time frame before they were using Freestyle Libre and then after Freestyle Libre. And what we can see here is that before Freestyle Libre, this population had a relatively high incidence of DKA at about 5.5%. And so that was the leading cause of hospitalizations for this population. And we saw that when we introduced Freestyle Libre in this very large population, we saw a significant reduction in DKA, a 56% reduction. And so that's a fantastic outcome. I think the other thing that jumps out to me on this plot is that it still remains one of the highest reasons for hospitalizations in this platform, in this population of users. And so although there's been a fantastic improvement, there's still a lot of work to do. And DKA is a very dangerous complication and one certainly worth addressing. Now, yesterday, Dr. Schur showed this slide highlighting that if you can continuously monitor ketone, you can potentially detect when it's rising and give a user, someone using the product, an early indication of that elevation. And that can allow them, with that early warning, to be able to take action and potentially avoid DKA. So we see a great opportunity here. And with that, I'd like to close and we can move on to the Q&A section. Thank you.
Thank you very much, Scott. I think that now we have time for some discussion. Again, I would like to invite who has any comment or question to send the question through the cloud system. So let me just start off with a few questions that I got so far. Federico, you have been showing data on people on a basal insulin, and someone is asking if you have any top tip to how to use, how to really the data generated by the continuous glucose monitoring to adjust the therapy in your type 2 diabetic individuals.
My suggestion regard the empowerment of the patient to the auto management of his diet. I remember a study of a couple of years ago, the Seoul protocol. The patient look at a postprandial glycemic profile and say, the food is non-healthy, I have to avoid the food. The food is healthy, I have to reduce the amount of food. So FGM is very important for the education of the patient to learn much better to manage his diet, to manage much better the selection of the food. Is of course important also for the physician, but the role in type 2 of this system is particularly for the education of the patient.
Thank you, Federico. Yvonne, I also have a question for you coming from the audience. Is statistical data from trials enough to change professional behavior of healthcare providers regarding if they adopt the recommending of Libre and the Novo 6 systems? In other words, do you see the data currently available strong enough to really start delivering it?
Well, actually, since we have these implementations, just I started my first people with diabetes 2.5 years ago. So this is a really novel innovation. And I think the data from the scientific literature is not enough to support it in a guideline, but I hope that we will have that soon within the coming years.
And I think probably needed to gain experience on that and also to digest and to learn how really get the best out of it, huh?
Yes, and I guess we have to get the clinical experience in order to set the questions for the trials,
Yeah.
because we should know what we want to answer.
Right. I also have a question for Emma. Could you provide practical suggestion for managing AID during labor and after delivery? So this is a very clinical question. You
Yes.
got the tool, how you want to use the tool?
Yeah, so we use CAMI PS in the UK, which was used in the ADAPT trial, and we can very confidently continue that through the labour process and just set a higher target so that when you get that sudden reduction in insulin requirements as the baby's delivered, the system will protect against hypoglycemia just when you set the higher target, and it will adjust for this change in requirements. And it just makes the whole transition from labour into that post-delivery phase far less stressful for us as healthcare professionals and also the women living with diabetes. So very positive experiences overall.
And now I have a question here that I've been considering provocative till a short time ago. And I'm sort of, offering this on a silver plate to my friend Tadej, but I also like to have the opinion of all the other speakers. And the question is a very simple one. Do you suggest the use of CGM for all type 2 diabetic people?
Do I have to speak up? I think, the basic thing that's important is that glucose is dangerous. Glucose is dangerous. A recent study that published glucose data on 12,000 healthy young individuals demonstrated that females have a lower normal glucose. Is this the reason why we have a higher mortality in females in type 1 diabetes? Because we use the same target. Is this why, the glucose during pregnancy is lower? Because it protects the fetal brain. So glucose is dangerous. So if we have a method to visualize glucose and act early enough to prevent the damage, this is what we should do. I'm listening to these lectures when a person has kidney failure and heart failure, I don't know what failure, and then this person is eligible for CGM and for medicines. It is 20 years too late. I would love to see the person on CGM, but the first glucose elevation was detected. And this is the good time to start disease-modifying medications and to monitor continuously to know that the person has normal glucose, perhaps even with a gender-specific target for the glucose. Happy International Women's Day again.
Today, women have lower glucose. You are implying something that I'm not going to agree with, that men are sweeter than ladies. All right, which cannot be, and I don't buy it. Don't buy it for sure. All right, but as I said, I also like to hear in the opinion of our other distinguished speaker.
Yeah, so I think we need to be quite honest here. 10 years from now, nobody is going to be finger pricking. It's just a matter of time until we get there. We're seeing more and more trials coming through supporting this. There's a systematic review and meta-analysis that was literally just published that showed improvements in time and range and HbA1c in people with type 2 diabetes, and the benefits were the same whether you were treated with insulin or not. So I think we're getting there. The trials are ongoing, but in my mind, this is where we'll end up. It's a matter of when rather than if.
Yvonne.
Yeah, actually, have to be honest. We see the data that CGM application reduce HbA1c by 0.45 up to 1%, and that's what some glucose lowering agents do, who all get reimbursed. So I think that it has the same power, but the power I see is especially in adapting lifestyle behavior, because it's so great for the people to see what exercise and food does to their blood glucose. And sometimes they have such a feeling of success if they have high glucose, just take a walk for 30 to 45 minutes and come back and immediately see that it changes their glucose, that it's now normal, and they were responsible for that. And I think that's a great issue in learning.
And Federico, in the Lombardy, you succeeded to get reimbursement for people with type 2 diabetes on insulin and even on oral glucose agents. So would you expect then the Lombardy to get and provide the CGM to all type 2 diabetic individuals?
Okay. Yes, it's yeah, I hope to have these results of these changes. The initial experience is extremely positive. The patient is really involved in the management of his therapy. So I think that the possibility of have a continuous information about their glucose profiles is strategic for achieving the better glucose controls in the cohort of a population.
I'm a strong believer, that action should be data driven. So, if you don't have the data, you just go by blind. All right. So I think that, that could be something that we can keep in mind. We are coming to the hour. We are coming to the end of this symposium. I hope that you can have found it informative and not just to provide you with a solution, but rather to provide you with some food for thought. And I think there are a number of things that we have to think about. One final thing that we need to think about after, having thanked Abbott for having given us this opportunity to discuss the data and ATTD to host this symposium, is that in the field of diabetes, the tools that were enhanced are incredibly increasing. Pharmacologically, in terms of delivering of the treatment, and also in terms of the monitoring treatment. So we have the tools. It's up to us to make it work. Thank you very much for being with us today.